Well, I think we've just got a few minutes left, but what I want to take a little time on is what's happening now with the global pandemic that we're dealing with. Everybody from around the world who's participated in this conference has been impacted by this, both professionally and personally. And I just wanted to share with you some of what we've done here at UCSF. We published a bit of this in a journal of neurosurgery, submitted it also to JAMA. And I just wanted to share with you what's been happening here over the past month and really what I anticipate being a part of our practice in the weeks and months to come. I'll give you a brief update on what's happening now, but early on when we were in shelter in place in San Francisco, and I certainly credit some of our local leadership for an early shelter in place. I think even though we had the first case in the U.S., many of you remember the Princess Queen cruise ship. So one of the very earliest cases was here in the Bay Area. But we've been able to avoid the surge that so many of us have feared, in part because of an early shelter in place, and in part because very early on, we put restrictions both on social distance in the community, but also we put some significant restrictions on our operating room. And I believe it was March 14th that we implemented a practice where we really stopped doing elective cases. And this is a tiering system that we developed where we talk about cases as being low priority or fully elective, then cases where we level 2 or tier 2, we'd say, well, typically in most practices, we'd schedule this within 3 months. So maybe people who have stable spinal disorders, but significant limitations, significant pain, significant disability, where we don't want to make these patients wait for an indeterminate amount of time. The 2B procedures might be more aggressive tumors, for example, but still without spinal instability, without progressive neural deficits. Then as we move up our tiering system, we go all the way up to a tier 3C, which is something that we really want to do urgently, quadric Quine syndrome, an epidural abscess, somebody with a fracture and a neurologic deficit, a progressive neurologic impairment. These are things that we've been operating on really all along since even in our restricted work hours. All of our tier 3 cases have been going. The emergent cases, truly emergent cases, actually they don't even fit into our tiering system. But throughout the pandemic and really for the past 5+ weeks, we've been doing tier 3 cases, and we've been trying to put off the tier 1 and 2 cases. And actually, we just announced yesterday that starting next week, we're going to open up the operating room to some of the tier 1 cases. So we've been doing tier 3 all along, tier 2 the last couple of weeks. We're opening to tier 1 starting next week. Christoph, how does that compare to what's happening at University of Washington? Christoph, you're on mute there.
I hope you can hear me now. So I think, thank you for sharing this slide. I think that's a very nice system. So basically, we always did 3 procedures, tier 3 procedures throughout. And now we opened up for two tier 2 procedures. And right now we're starting to schedule a fully elective again, end of May. So that's kind of our start up again. So basically right now we're in the transition between 1s and 2s where we kind of do that. It's amazing how quickly those cases line up, and it's not infrequent that these cases then sort of start calling, have ER visits, and then you have to, I think you really have to act quickly. You don't want to expose your patients to unnecessary emergency room visits, especially patients with intractable pain.
What are you doing now in terms of mandatory COVID testing? So are you requiring that all patients be tested before surgery? And if somebody is not known their COVID status, then what are you doing in terms of special precautions?
So actually, that's something that we started now almost 3 weeks ago. So all elective cases are COVID tested. And I actually had one patient so far. She was asymptomatic and she was COVID positive that we delayed for that reason. So As you can imagine, the precautions are very different from a COVID positive patient versus another patient. We do, however, even if the patient is negative right now, the whole team leaves the OR when the patient is getting intubated, just to minimize the exposure to aerosols, except for the anesthesia teams. So there's a couple precautions that we have. I think the most important thing is testing. And once you know that you are at danger, I think then you have to change the strategy and your protective gear. But I think once I think it's important for us to slowly, or as quickly as possible, return to normal operations. I'm sure I've heard, is a lot of hospitals lay off healthcare workers right now because the profit margins are not there, which is it's absolutely absurd. But and so I think it's our responsibility to just safely utilize the resources we have. And I think testing is important. I think those tier systems are important because they help us to really select the patients very objectively who need to come first. And I think we have to continue to work hard to take care of our patients safely.
Our experience with the mandating testing has been a difficult transition. There are a lot of considerations with regard to the difficulty of getting reliable tests done before surgery. Right now, our policy as of only last week has been to mandate a negative test done within 72 hours of the time of surgery. Having said that, that still leaves us with a significant window during which patients may be exposed. And a lot of our patients here are traveling long distances, plane flight type distances. And to that end, the exposure and risk of the plane flight, of staying in a hotel before surgery, after travel, these are all very real considerations. So that's been a bit of a burden with regard to the mandatory testing requirements, and has really limited how many people have been able to access surgery since we've had mandatory testing. But I want to make sure everybody understands that the experience out of Wuhan, in a very important publication, I think it came out in the New England Journal, of what happened to the patients who were asymptomatic and subsequently found to be COVID positive. The morbidity and mortality associated with that was really quite dramatic. And in fact, 20% mortality of patients who had an elective surgery, they were asymptomatic and subsequently found to be COVID positive. So the combination of the stress of recovering from surgery, perhaps to some extent the stress of intubation, really puts patients at a high risk of perioperative complications. And I think that's something I've really been emphasizing with my patients, who many of whom are very understanding about the need to delay surgery, to postpone surgeries, but many of whom really want to move forward with disabling pain, with disabling functional limitations, and recognizing to what extent is a priority for patient safety as well as staff safety to try and avoid unintentionally operating on an asymptomatic positive patient.
In terms of clinic, I'm sure you do telemedicine too. So we switched everything over right now. So we have roughly 80% telemedicine. And my default right now is telemedicine, which interesting has been a gigantic time sucker. It's really difficult to get a patient onto a imaging device or a computer. I think the time that is wasted there to get everything set up until you really have the patient in front of you is dramatic. I recently did a clinic visit with a patient driving, and it is quite an adventure. So I think you kind of start appreciating how easy it is to walk just in a patient room and have the patient right in front of you. They're not distracted. It's amazing. But I think we have to, take the challenge. I think the good thing is coming out that I think patients follow up, especially after small surgeries. I'm looking forward to going to do with telemedicine going forward. And so I think there's some visits that or like a 1-year routine follow-up for an arachnid cyst. I mean, you just want to check in that they don't have any progressive gait issues. I think there's some visits I think that you can easily do in a 5-minute telemedicine conversation. What is your experience with that, Sig?
Yeah, Christoph, I was initially also really quite a critic of the telehealth option. It was slow, it was laborious. Patients logging on was frustrating. I would say more than half the time, without exaggeration, I converted to a telephone call. Now, having said that, we've really become much more facile with this, and despite the fact that I didn't shut off my mute button, we've become much more facile with this over time. And now I think that there are a number of cases that I'll probably default to a telehealth on. Certainly anybody who's got to drive more than a few hours for a routine follow-up, if they don't have any problems, I'll absolutely default to a telehealth on that. We're getting x-rays done locally for many patients, so they'll send in the x-ray, and lots of times they just want to take a look at their x-ray and do a 1-year or 2-year follow-up. The other subset that's interesting that I may choose to do more with telehealth is actually the initial consultation. And the reason I say that is it's not uncommon. My practice is almost exclusively patients who are referred from other spine specialists, and it's not uncommon that there's some other imaging study or something else that I might want to get on that patient that results from the first visit. It may be a neurology consultation, it may be an EMG, it may be a CT scan, but it's not uncommon I want to get some other study. And oftentimes, I think, especially the patient driving a long distance, if I could have an initial visit, and then when they come to see me for the first time, we're ready to talk about surgery because they've got everything they need to have done. They've gone through, I've got a very rigorous preoperative optimization program. They've gone through the preoperative optimization. If somebody comes to see me at initial visit with poorly controlled diabetes, with a BMI more than 35, somebody who's got reversible comorbidities, then there's a lot of opportunity there to say, hey, come see me when you're really prepared for surgery, both in terms of the studies as well as physiologically prepared.
I think it's a good point. I think also keeping the mute button on so is going to increase your breast Gini scores with the patient.
Well, terrific. I think we've gone a little bit over time. Ron, are there any pending questions at all that Christoph and I can address?
The only one I see is from Dr. Taliaferro, who's asking, dealing with being at an academic center that limits elective procedures, whether local hospitals are allowing elective spine procedures. I've had to leave my facility to get surgery done somewhere else despite it not being a non-emergent case. Are you hearing that from other physicians as well?
Well, I want to send a hello to a very fond hello to Dr. Taliaferro. Dr. Taliaferro is working in Detroit now and was our fellow a couple of years ago. And I know he's building a very busy, complex spine practice out in that area. And so I know that Dr. Taliaferro is doing some very similar complex cases that we're dealing with here. So in our community, we've actually been the go-to hospital for complex cases, and that's why we've stayed open for certainly the Tier 3 cases, and also in the last couple of weeks, the Tier 2 cases. And to some extent, the referring hospitals and community have really had much more limited access to surgery, I think quite appropriately. So we're actually seeing more referrals of complex cases over this period. So to my knowledge, the community hospitals have really appropriately actually limited elective surgery even more so than we have here. And again, that's my big concern, is people being too enthusiastic to open up to business as usual, because I could tell you that the exposure that comes from one unrecognized COVID positive patient, and we had that experience recently, 40 people become exposed, even with precautions used. But one patient who's not treated with the most rigorous precautions, it's bad for the patient and it's bad for the staff in the hospital.
So, Dr. Berven, the next question is, what does a typical telemedicine visit look like? Are there patient forms that help provide information regarding range of motion? pain scores, et cetera, within telemedicine? And how do you assess a patient virtually?
Christoph, you want to take that one?
I'm actually, I'll let you, there's actually something that might be of interest. I'll try to find it in my email right now. Our hospital has given us a little blurb that you have to put into the notes so that you can bill for it. So I'll try to find this and copy that in there. It's kind of like a little statement that you have to say that, you had, consented verbally the patient that you do a telemedicine visit and something. So a little bit of a language that might be interesting to the listeners. Other than that, I think, we do have patients of the team call the patient. They're trying to set up the telemedicine visit with them. And then they put the patient into a Zoom waiting room. Then afterwards, I think that you get better at it's taking the history, and then I let people walk. Typically, I like to see how they're walking. Strength exercises, you can do anything that is a strength measurement, anything that is anti-gravity. Again, like you mentioned, it's a mixed bag. I think sometimes you look at a patient at their home and you see if they have a social network, if they, what it looks like, and it's kind of, you do get to know a different aspect of the patient, which is to some degree interesting. So I think it's not going to go away. I mean, I think telemedicine is now here to stay. I think the interesting question of patient outcome scores. We are right now working on an app to follow these patients in terms of outcome scores. So that is something that we have not had time to really implement as of yet. The outcome scores are getting lost with those electronic follow-ups. So I don't know if you are already up to date on that.
Yeah, I think the telemedicine visit is definitely compromised, and I don't know if it'll ever really match a face-to-face visit in terms of the rigor of the exam. I'll just tell you briefly what we do is all patients, before they get scheduled for a telehealth conference, they fill out our intake questionnaire. So that includes a pain diagram. It includes some health-related quality of life information. It includes some of their history. So we do get our patient-reported outcome scores. We do get a pain diagram that I find so useful. But in terms of really assessing a patient, assessing their sagittal alignment, I think we all try. We have the patient step back from the camera, watch their gait, look at to some extent an exam. But there's really never going to be a complete substitute for laying hands on a patient for that kind of rigorous evaluation.
According to our coder, that's important to have these little phrases. They want to have buzzwords. So, via secure live face-to-face video conference, blah, 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 located at home alone, blah, blah, blah. You do you ask him a verbal consent and stuff. So I think there's some language in this that might be useful. Do you have something similar to that, Sig?
Yes, very, 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 very similar. Documenting the use of telemedicine. I recognize now that I can see the questions. I didn't understand Dr. Taliaferro's question initially, but one of the things he observed was that other hospitals being open in the community, so patients who were not actually urgent cases being done in the community. And gosh, Kevin, I share frustration about that. I think that that's opportunistic. I think that that's in many cases really inappropriate. I think I haven't seen that problem here in our community, but the idea of somebody saying, "Hey, we're open for business. You don't need to get screened. You don't need to have. You don't need to worry about this." That's really not the way I think most of us would want to practice medicine. I think it's awfully important to recognize that the risks of patients are being put at with regard to surgery, and again, operating on somebody who's asymptomatic but COVID positive, the patient impact on that is significant in terms of morbidity and mortality. So hopefully, as we open up the ability to safely operate more broadly, that won't be a problem going forward.